Hello and welcome to today's class, the class about TMD and Bruxism. Do you need to be a specialist in TMD to treat Bruxism? If you have this question, or if you're convinced that yes, you do need to be a TMD specialist, I want you to stay with me until the end of today's class so I can explain how Bruxism is affecting your daily clinical practice. You might not be noticing this regardless of your specialty. This week, we are getting ready for next week, which is the Advanced Dentistry Week. It's a week where I will teach you how you can become a reference dentist in your region, increasing your income even if you don't charge for consultations or currently accept health insurance through differential diagnosis, treatment, and management of bruxism. So there are only 5 days left until this event, just 5 days. And this week I am doing live streams every day. Next week's event is a closed event. So you need to click here in the YouTube comments or on the Instagram link to register for free. By joining the WhatsApp group, you must not leave the WhatsApp group because that's where I will send numerous materials, PDFs, everything that will help you in your daily routine. So today is Wednesday. We are still in the preparatory week. Tomorrow there will also be a live. Friday there will also be a live. And on Monday we start the big week of dentistry in the sky. Now, for those of you who don't know me, my name is Andrea Melo. I am a dentist, graduated from the State University of Rio de Janeiro. I have a master's degree in material science and a doctorate in dentistry from UERJ. And I also have a master's degree from the Military Institute of Engineering. And a doctorate from ERG. I did prosthetics, I did periodontics. I work in the dental chair just like you, in addition to dedicating myself to a teaching career. Since I was very young, as you can see in this photo, it's been more than 15 years. In fact, it's already been 16 years that I've been teaching. I've been graduated for over 18 years. And from the very beginning, I've committed myself to an academic life combined with working in the dental chair because I believe in the teacher who teaches, but also in the teacher who practices. I know all your struggles as a dentist because I am one too. So your challenges when facing a patient, wanting to offer the best for the patient and often having to negotiate with them, and they don't understand why you need to do that treatment for them. I know what that's like. And I want to show you how Bruxism can change your perspective on dentistry within your own practice, with the patients you already have today. And often you have the belief, you think you need to be a specialist in TMD to treat Bruxism. So I want to tell you that everything you're going to learn here is based on science, on scientific evidence, and on clinical applicability. And I know that often life is hectic. Everyone's life is hectic. Information comes at us so fast. Patients want things done yesterday, and you have to work more and more, getting to the office earlier and leaving later. That's painful because we end up with no time for our family, no time to watch our children grow up, no time to enjoy life. And that's not why you studied dentistry, not to live inside a clinic without ever seeing the light of day. I want to tell you that our lives really can change, and it's very important for you to become a reference dentist for that to happen. So how can you become a reference dentist in your area? By standing out from the rest. Let's stand out and let's understand what's happening with the patient's profile today in our clinic, what's happening right before our eyes, and often we're not seeing it. So let's get started. I want to start today's lesson with the anatomy of the TMJ. Why? Because the patient has changed, and you need to change too. Andrea, I don't want to be a specialist in TMD. I'm not saying you need to be. Pay attention, TMD isn't for everyone. Bruxism is for everyone. TMD is for those who want to work with pain patients every day, all day long. The TMJ, the anatomy of the TMJ, any dentist who does restorations is involved with changes in the TMJ and often doesn't even realize it. I'm going to show you that in today's lesson. And any dentist who sees patients is involved with bruxism. And often you don't notice it, but it's happening right there in your office. It definitely happened today. So we need to understand that the TMJ is a structure with spaces that must be respected. There is indeed a relationship between occlusion and the TMJ in terms of three-dimensional positioning, but understanding the anatomy of the TMJ is for every dentist. And regarding the consensus on orofacial pain and disorders, we need to understand that the TMJ consensus states the following. There are two types of TMD. This 2012 consensus says there are two types of TMD. There is the muscular type and there is the articular type. Muscular TMD accounts for 90% of our TMD cases. And often this muscular pain can be managed by you, by a team you recommend, or even by your own office team. Remember that not every bruxism patient experiences pain. Not every bruxism patient has muscle inflammation. Not every bruxism patient has issues related to joint problems. No. But every bruxism patient who experiences muscle pain is dealing with centric clenching, which can even happen in the morning, okay? There are two types of bruxism. There is daytime bruxism and nighttime bruxism. This needs to be noted. This needs to be understood. And often this muscle pain is related to this bruxism, which can even be uterine bruxism. So stay with me in today's class so you can understand some important concepts about occlusion, condylar positioning, and TMJ anatomy. Is there a relationship between occlusion and condylar positioning? Yes. Is there a relationship with the biological space of the TMJ? Yes. And maybe you're thinking, this is too much for me. It's not too much for you. You don't need to get involved with the pain. You need to get involved with bruxism. I'm going to explain all of this to you during Advanced Dentistry Week. What is the management of a patient with bruxism? How do you treat a patient with bruxism? Whether or not they present with pain. Because even if the patient doesn't have pain, they still need treatments, which many times is not just the splint. In fact, it's never just the splint. The splint is just a small part of bruxism treatment. Come with me. There is a relationship between occlusion and the condyle. But not every patient with TMD has occlusal problems. Did you know that? So I'm going to separate the entities: TMD, occlusion, bruxism. These are three different entities that interact at certain times and are often risk factors for one another, but they are not the same problem. I can't put them all in the same box because the literature is very clear about this. The literature is clear that not every patient with TMD has occlusal problems. Did you know that? And maybe you're thinking, wow, but I always learned that occlusal adjustment solved both TMD and bruxism. And I want to tell you that this is no longer believed. It's already proven in the literature that TMD is a separate entity. Now, what is the click? There are a lot of patients who have a click, right? Check out this video. It's really cool. It's an anterior disc displacement with reduction. Maybe you heard about this back in college and never heard about it again. So let's take a look. This image is a histological section. It's at the front. It's actually a cadaver. It's a cadaver. It's in front of this other image. So when we open and close the jaw, the disc moves back and forth. I'll show you in this image of the skeleton here first on your right, okay? So open and close. The green part is the disc. Take a look. The disc is in a normal position. It's moving well, opening and closing. That little ball behind the condyle is the ear. And every dentist needs to know this anatomy. Now, when the disc is displaced, look what happens. It moves forward. See, with reduction. There, it went back, it set in place. Again, now it's going to close. It's going to close. Okay, and it pressed that area behind the disc. See, it's set in place again. Again. Now it's going to set in place when closing. See, okay, it's set in place. Now it's going to set in place when opening. See, there, it's set in place. What does this mean, folks? When I have a disc displacement with reduction, it's because it goes back into place at some point, and then it clicks. When I have a disc displacement without reduction, it moves forward and never comes back, neither when opening nor closing. And what does this have to do with bruxism? Nothing. But what does this have to do with TMD? Many times, the patient who has a displaced disc feels pain when, at this moment, they compress the area behind the disc, which we call the retrodiscal zone. And it's a pain because it's a very innervated area. So not every patient who has a click has pain. Have you noticed that? There are many patients who have a click but don't have pain. But there are also many patients who have a click and feel pain due to the compression of this innervated area. So when we talk about pain, that's why I told you that with TMD, you don't necessarily need to get involved. But with bruxism, yes. When the patient is in pain, you need to treat the patient's pain. And we are going to find out the cause of this pain. Many times the pain is muscular and will require periodic management. Now, can bruxism cause muscle pain? Yes, it can. Why? It is an amplifier. It amplifies the problems the patient has in the oral cavity and in the supporting muscles. It's an amplifier because you exert a lot of force where you shouldn't. So understand bruxism as a movement that can be rhythmic or not rhythmic, that is like this or like that. It can be phasic or centric, right? Or tonic. It's a problem for any other condition in the mouth. For example, if you have a clicking sound and it's associated with bruxism, you might start to feel pain. You might start to have more wear. You could develop another problem, even a joint problem. Yes, but that's not bruxism treatment. Did you get the difference? I'll move on. Occlusion. Maybe you're thinking, wow, occlusion, I don't even want to talk about occlusion. Every dentist treats teeth. So every dentist who treats teeth needs a proper bite alignment. You know that tooth right there? Look, it has mechanical force applied directly on it. A bruxist exerts much more excessive and much more constant force. And even if you just recently graduated, this is for you too. Even if you've been practicing for a long time, this is for you as well. Because you're doing restorations every day in your office. you're doing restorations, your work revolves around teeth, and you're affecting the TMJ, whether you want to or not, whenever you change an occlusion. You're altering the dimensional positioning of the TMJ. The patient may or may not adapt to this. A patient with bruxism has a harder time adapting to anything you do in their mouth. So if you did a high restoration and the patient has bruxism, it's going to get worse. They will experience more pain. They might even feel pain in the ear area because of a high restoration. Why? Because bruxism amplifies it. Do you understand that bruxism has become part of every clinician's equation? You can't just close your eyes and say, I don't need to check if the patient has bruxism or not because I'm not going to treat it. No, it's actually the opposite. You need to check if the patient has bruxism or not to know what you're dealing with and whose mouth you're working on. Why? It's one thing to know that the patient has bruxism, and I'm going to teach you here. There's an exam you can do to check for it. If I see that the patient has bruxism, I explain to them, look, if you have a high restoration or any other adverse situation, let me know right away before this develops or triggers a problem that is often uncontrollable. Because once pain sets in, getting rid of that pain becomes much more difficult. So it's very important for you to understand where you're placing your restorations, your implant, doing your endo, so you don't get any surprises down the road. There are 3 types of occlusion. The ideal occlusion is where the centric relation is the same as maximum intercuspation. We have physiological occlusion, which is the absence of signs and symptoms. This is generally the occlusion we aim for, the one we are adapted to. And there is also pathological occlusion. Every occlusal dysfunction is related to a pathological occlusion. What would be a pathological occlusion? An occlusion, for example, with the absence of canine guidance. It's an occlusal dysfunction that will cause what? An abfraction. The result of a pathological occlusion, you see? So what would that be? Can an occlusal dysfunction be self-limiting within TMD? Yes, I can have an occlusal dysfunction, not have canine guidance, and not have any pain. But what will it cause for me? It will cause me an abfraction because of the lack of canine guidance. Once I have an abfraction caused by the lack of canine guidance, I can't say that's a physiological occlusion, you know? Because I have a sign there, which is what? It's an abfraction. So be careful not to normalize problems that are actually showing evidence of a pathological occlusion. It's not physiological, it's an occlusal dysfunction that has produced a sign, a symptom. Bruxism, in this context, bruxism increases these issues even more. These signs and these symptoms, it speeds up the appearance of an abfraction, for example, in a patient who doesn't have canine guidance. Bruxism is an amplifier, it's an accelerator of the problems that will arise. Can this cause a TMD? No, it cannot cause a TMD. And at this moment, I want to congratulate you because you just learned something that a large part of our profession still doesn't know, but will eventually learn. I want to congratulate you for being here, truly learning this. Why? Occlusal dysfunction, for example, a restoration, a simple restoration that is too high, can indeed cause a unilateral bite. It can often cause a diastema with mobility, a vestibularization, a recession, for example, if you have it associated with a premature contact on the lower incisor, which has a thin periodontium combined with bruxism, amplifying that occlusal load. Can it cause a recession on the buccal side? Yes, it can. So wear facets, changes in centric and eccentric patterns, all these occlusal dysfunctions are not normal. They are evidence that something is wrong. It is not in the physiological function, in the physiological occlusion that it should be. But that doesn't necessarily mean it will cause TMD. There is a margin of self-limiting functional and aesthetic adaptability. So, for example, I did a high restoration on a molar. The patient started saying, it hurts, it's big, it's high, and then it went away. 2 weeks later, the patient comes back, or a week later, and they don't feel it's high anymore, even though you didn't adjust it. What happened? The mandible made a slight rotation here and compressed the contralateral side of that high restoration to avoid the high spot, a proprioception mechanism. And this means there was rotation, accommodation, adaptation of the mandible, and changes in centric and eccentric patterns. Is this phenomenon capable of causing TMD? No. There was an adaptation of the system to that high restoration. Does this adaptation happen to everyone? For most people, yes. What happens with the small percentage who do have it? Degenerative tendencies, had vitamin deficiencies in childhood, for example, currently has hypovitaminosis, has reduced collagen production capacity, has hypermobility. I'll add some other factors here. Who sleeps poorly? Yes, who sleeps poorly? In the past, we used to go to sleep at 10 at night. And now, with this amount of light in our faces, with this amount of electronics in our faces, 11 o'clock, midnight, 1 in the morning. There are people who work until midnight on the computer. That's right, folks. This means the following. Our capacity to produce disease is increasing. So when we find some of these factors in certain people, it can indeed lead to dysfunction. Dear, this isn't difficult. This is often unknown. Sometimes you say, oh, wow, this isn't for me. Bye. No, this is for you because you deal with patients who have this problem every day. And I'm not inviting you to become an expert in ITM. I'm inviting you to stay with me and join the Advanced Dentistry Week so you can see how I'm going to bring a methodology that you'll learn from start to finish so you can treat bruxism and become a reference in your region. So come with me for next week. Look, I brought the scientific article. I told you everything was based on science. Thank you. I brought you the scientific article that shows go to the clinical significance section right at the end of the article. I even enlarged it for you that malocclusion does not impact the presence of bruxism or TMD. Look how interesting. Look how interesting. However, we have to reason as follows. Malocclusion should be reconsidered in contemporary restorative and oral rehabilitation dentistry. Contemporary. Awake bruxism, however, look there, but awake bruxism and sleep bruxism can be associated with significant muscle pain and discomfort, particularly in the jaw area and facial muscles, leading to soreness. Muscle pain, it can happen because I just explained it to you. It is an amplifier. So get it out of your head that the patient will have TMD just because they have malocclusion and bruxism and that it's all the same thing. These are separate issues. Not every patient with malocclusion will have a problem. And not every patient with bruxism will have associated pain. Some will, others won't. What will all of them have? An amplification of oral cavity problems. If there is occlusal interference and bruxism, there will be faster wear, for example. And now shall we talk about the physiology and pathology of bruxism? Is bruxism physiological or is it pathological? So pay attention to the nuances of bruxism. All of this that we are discovering over time. Things have been changing more and more over time. So you need to think outside the box. Thinking outside the box means understanding that occlusal splints, that occlusal guards are neither the best nor the only treatment for bruxism. Why? Because that's also shown in this study. There isn't enough scientific evidence to conclude that splints are the best treatment for bruxism. Look, their use is questionable. Their use is questionable. There is a certain benefit when it comes to dental wear. I'm just translating what's written there. With dental wear, this systematic review, which I love systematic reviews, the compilation of articles according to the criteria, which is important, suggests that more research on splints is needed. Attention, do not base your bruxism treatment solely on splints because it's showing here that it's not necessarily the most important thing and that their use is questionable. But are there occlusal splints to reduce dental wear? Yes. And there's another issue as well. Sleep apnea is involved. There is bruxism secondary to apnea. This bruxism secondary to apnea, often the patient needs a protrusive splint, okay? So I know we were trained to deal with the consequences of bruxism. What are the consequences? Dental wear, fractures, all of that. But what I want to bring up is the cause of bruxism. So I'm going to get into a rehabilitation case here. I'm a rehabilitator. I'm going to discuss a rehabilitation case. And every time I do a rehabilitation case, when I'm going to change the patient's entire occlusion, I do a condyle CT scan. That's standard procedure for me. I do a condyle CT scan and look at the biological joint spaces that I mentioned at the beginning of the lecture, that there is a space in the TMJ. Okay. What did I see in this patient's CT scan? An erosion in the condyle. An erosion in the condylar area, it was being compressed. This is another relationship between occlusion and condylar positioning. And then I do my entire rehabilitation. This patient is still with lower provisionals. And we move on to the preparations over the mock-up, minimally invasive, taking every precaution. And what did I see afterwards, before preparing and after changing her vertical dimension of occlusion, that is during the provisional phase? What did I see? I saw that during the provisional phase, we had an increase in the condylar space, obviously, because I increased the dimension, and I can see this in the CT scan. The increase in this space provided more room for the supporting tissues and the erosion. In other words, that little wear she had on the condyle, which you can see in CT scan 1, is no longer present in CT scan 2. In other words, there was beneficial remodeling for the patient after we created an ideal space by increasing the vertical dimension of occlusion. So look how interesting this is. Is there a relationship between occlusion and the TMJ? Of course, with the TMJ, of course. But can I treat a patient by increasing the vertical dimension and say that they will be cured of TMD? No, because there are other causes. Just like with bruxism. Bruxism, now we're getting to where I want to go. I explained this whole path to get to this moment now. We talked about the disc, we talked about disc positioning, we talked about what a normal disc is, what a displaced disc is. Here's the image. We talked about this articular space. We talked about having pain and not having pain. And now I'm going to get to the highlight of the lecture. Sleep stages. We worry so much about occlusion, and we forget that our patient is sleeping poorly. We forget that every bruxist sleeps poorly. So we were taught to deal with the consequence of bruxism, which is dental wear. But we forget the most important thing. Why is this patient sleeping poorly? Why can't this patient reach the REM and non-REM 3 stages, which are important for them for hormone production, for maintaining homeostasis? So we go to technique courses, we do the best implants, the best implant courses, the best preparation courses. We learn to be minimally invasive, but we leave the patient sick, sleeping poorly, and with a beautiful veneer. But what will happen to that beautiful veneer? If they continue without ideal sleep, they're going to break that beautiful veneer. And if they continue without ideal sleep, no implant will last. So pay attention. Let's stop just mopping up the problem in dentistry and understand that the mouth is part of a body and that body needs to be healthy. And again, for you who are still with me at this point, I want to congratulate you because you're going to understand that there are 4 stages of sleep and that bruxism usually happens in stages 1 and 2, which are the light sleep stages. Stage 3, non-REM and REM stage are the stages where there is a hormonal surge, GH production, and memory consolidation. All of this is essential, for example, for a child to grow. And for an adult, it's essential to prevent Alzheimer's. So we're worried about technique courses while our patient is sleeping poorly and no one is taking care of that. But often, we who are right in front of the patient's mouth are the first healthcare professionals to notice any evidence. For example, a worn canine tooth. A doctor can't see that during a consultation. A general practitioner, a physician, can't see that the canine is worn down and that this could mean the patient is sleeping poorly. They can't see that. This is something wonderful about being a dentist. So we dentists need to think in 360 degrees because we are facing a huge opportunity to treat and control what is harmful to our patients. And many times we are neglecting this. So a complete cycle of non-REM and REM sleep phases averages about 1 hour and 50 minutes or 2 hours. Every 2 hours, your sleep cycles, and there is a latency between these sleep cycles. So considering an ideal average of 8 hours of sleep, that's 4 cycles. How many cycles do you go through? How many cycles does your patient go through? Are we really able to get the amount of deep sleep we need? And I know you might be thinking, this isn't really for me, but I want to tell you, it's not that, it's just unfamiliar. Do you know what I'm doing with this patient? She's a patient who came in because of bruxism. Actually, she came in to fix her teeth. She was experiencing sensitivity and loss of dimension. I'm palpating one of her trigger points. I'm not injecting Botox, no. It's a carb. Skip that part. I'm following a protocol for managing acute muscle pain. And for that, you don't need to be a specialist in TMD. During Advanced Dentistry Week, I'm going to explain to you the protocols for managing acute muscle pain so you can boost your career and connect with your patients. So patients connect with those who relieve their pain, and you can be that dentist right from the initial consultation, the very first appointment, the first week, even the first moments you're with that patient. So protocol for managing acute pain, goodbye. This will often make the patient's masseter muscle less hypertrophied, less prominent. She herself sent me this message. She said, "Doctor, look at the contour. It's already getting better." This one is simple. Because it's the muscle that was inflamed and swollen. And not a single % of dentists know this technique with a beginning, middle, and end for treating bruxism and managing acute pain. So if you don't charge for consultations, performing an exam, managing acute pain will increase your revenue with a lot of integrity. Making a differential diagnosis will increase your revenue with a lot of integrity. 1. Pay attention. I'm going to give you a little preview now of what I'll talk about during the Advanced Doctor Week, which is differential diagnosis, okay? If you don't charge for consultations, start performing differential diagnoses and you'll be able to add value to your consultation and charge for these additional differential exams. So I brought here an overview of bruxism, right? Within this literature, talking about the issue of individual health of bruxism. It is not considered a disorder, but rather a behavior at that moment that can be repetitive, rhythmic, or not. Now, very important, it is not a TMJ disorder. Bruxism is not a TMJ disorder. It is a movement. It is a movement that the patient makes and amplifies all the problems of the So how am I going to diagnose bruxism? What do I do? Am I going to wait for the canine to wear down? No. 4 steps of differential diagnosis. I will break this down during Advanced Dentistry Week. 360-degree patient record. Extraoral and intraoral evaluation that includes muscle palpation, complementary differential exams, diagnostic splint examination, sleep polysomnography, closure, and support. Why? This differential diagnosis has value and you are going to charge for it. Why? You are showing that it's not just a quick look at the patient. It's not just a quick look at the tooth. It's a differential diagnosis with complementary differential exams that you will perform in your office. You're not going to change your first consultation. You're going to improve it, update it. And I want to tell you that this 360-degree patient record will open up a huge opportunity that you might not be experiencing or even seeing today. So pay attention. This is a template that I give to my students. My students who are already mentored by me, many of whom also came from health insurance plans. She didn't used to charge for consultations. Now, she already charges for the diagnostic splint, exam. The patient came in with wear on the front teeth and jaw pain. The patient thought it was necessary when she mentioned the diagnostic splint exam. I'll show you so you can see what it is. And she charged 500 rays for the exam. It showed moderate eccentric sleep bruxism, mainly in the area of the incisors and premolars. And she proposed the treatment. So take a look. Patient with a lot of wear, already at a high level for his age, and the 360 medical record. This medical record can be filled out by the patient at home or at the reception desk. You can send it via a Google Form link. It's a 360 medical record. It's not just questions about teeth, toothbrushing, or whether the patient has had any heart issues or not, like many dental records often are. It's a record that includes all the oral hygiene questions as well as important questions about the patient's behavior. When we talk about patient behavior, we're already thinking about bruxism. And look how interesting. The patient wrote down the start date of the problem is 2015, so he can report how long he's been feeling wear on his teeth and pain in his jaw. Guys, sometimes the patient has been suffering for 10 years, almost 10 years of suffering, and he reports that he notices the wear happens while he's sleeping. And what happened to him during those 10 years? Nothing, because he didn't find a dentist to really break down bruxism with him. So let's update ourselves at this point in history post-pandemic because the patient has changed. This is the diagnostic splint exam. It's a completely red splint. It was red on the first day, and this dye doesn't come off with water, only with friction. I published this in 2019. Since then, I've been doing it with all my patients. Just like we need an X-ray, we need a diagnostic splint exam to know what the patient does at night. Remember, your patient is sleeping poorly and you don't know it. You don't know what he does to your restoration, to your root canal, to your implant when he sleeps. And here's the result. This is what he does to your restoration, to your root canal, to your implant when he sleeps. And this is extremely important for you to ensure continuity, longevity, or even a warranty or not for any dental treatment. Because if the patient does this at night, you can't, for example, guarantee the implant for years. You can't offer a warranty. You need to make a note of it. You need to make it clear that this patient makes this nighttime movement and only then move on to the treatment that I'll be teaching during Advanced Dentistry Week. So the patient makes a lot of movement. You see, he ended up removing all the ink from the plate, showing that he makes repetitive and rhythmic movements to get rid of all that stuff. Red ink content. So you're not going to stop your endo. You'll do your endo plus the diagnostic plate exam plus bruxism treatment to ensure that this patient improves both their quality of life and the longevity of their dental treatments. And what is this? This is a second complementary differential exam, which is polysomnography, so that we can see what if the patient desaturates, that is, if their oxygen drops during the night or not, because there is bruxism secondary to apnea. In this bruxism secondary to apnea, when the oxygen drops, the brain understands that it's dying, sends out adrenaline, the heart races, especially increasing cardiac risk, the heart races. And then there is a type of bruxism that we call secondary bruxism. The secondary factor is the apnea. This patient does not have this secondary bruxism. The IDO came out as 6.1, which is within the normal range, just starting to show mild apnea. So it's important for us to understand that apnea is a progressive disease and that we are going to manage this patient at the beginning because he is at the onset of this apnea. He doesn't necessarily need to use a CPAP or anything like that. Now perform this test, give the diagnostic exam, Differentiate the diagnostic splint. If the diagnostic splint exam shows bruxism, do this test to find out if it's secondary bruxism, apnea, or not. So sometimes the patient might just need to lose weight. For example, reduce the neck circumference. Let's see how he is. He might just lose weight. And that very mild sleep apnea, which is just starting, could already be resolved. So who is going to tell him that? You. Do you understand how you become a reference? You set yourself apart. A distinguished dentist becomes a reference because you will give this information to him that no one else has given. So it's at this moment that you become the best in your region. It's at this moment that you stop doing the same as everyone else. It's at this moment that you manage to implement something truly unique. And that's why I want you to join me for Advanced Dentistry Week. Because I'm not even talking about treatment yet. I'm just talking about differential diagnosis. And I've already given you a ton of information here that will make you stand out in your region. Just imagine when you actually start treating bruxism for real. Those patients who already have a mouth guard and don't even use it, you'll tell them that's not the solution, that you have a treatment, you have a proposal, a much better treatment option for them. And I want to remind you of something. Is diagnosing bruxism just seeing a broken tooth? No, that's a consequence. That's evidence. In the class I gave on Monday, I said that's evidence of bruxism. Is it seeing a worn down tooth? Is it seeing a patient without canine tips? Is it the patient who has canine tips and the patient who has canine tips and also has bruxism? So there are patients who have canine tips and have bruxism. And you're only looking at the canine tip to determine if they have bruxism or not. So be careful with these concepts. Thank you. From the last century, from the last decade. Be careful with that because we're living in a different time now. It's a time when everyone sleeps poorly, a time when everyone works a lot, a time when everyone is clenching their teeth. And you can't say whether your patient currently has bruxism or not just by looking at worn down teeth. Because they may have had bruxism in the past, lost dental volume, and now are no longer doing it. So a diagnostic splint examination is necessary. So I want to prepare you for this, not always worn down. Not every worn down tooth means this patient, for example, had worn teeth. And look at her bruxism activity, practically zero. So she had worn teeth but didn't have active bruxism at that moment. See how important it is to do this complementary differential exam? It's super important, and I'll teach you this during Advanced Dentistry Week. And this gives you an opportunity for extra income. In other words, in addition to your consultation fee, if you already charge for consultations, even better, because you'll be able to monetize your consultation even more. And if you don't charge for consultations, you can monetize by offering this complementary exam, this differential complementary exam as a financial gain right in the first appointment. Financially, in terms of authority, it will increase longevity. When we start talking about bruxism treatment, it will increase the longevity of your dental treatments. This will give you security, and you can then start thinking about working less, having more time with your family, and retirement. Remember that bruxism treatment and the diagnostic splint exam, these consultations don't depend so much on your back or your hands, on your eyes, and that's why, even if you've been practicing for 40 years, this is the right moment for you when it comes to bruxism. I want you to listen to what my student Sergio, who has also been practicing for 40 years, has to say about what this exam and bruxism have done for his career. Look how interesting this is.
I'm 69 years old, and I've been in this profession for over 40 years. Before I learned about Andrea's method, I used to just put up a little sign because that's all we had at the time. Now I'm reaching out to many of my former patients, bringing them back to my office with a new proposal for treating bruxism. I'm really excited about this. The diagnostic splint is an open door to closing the treatment. Another thing is when the patient learns about this possibility, they accept it. You can present the diagnostic splint to them, and they pay willingly because they realize it's something tangible and different. They can see it, you show it, you prove that bruxism is there. Currently, I consider myself an authority when it comes to solving these cases of bruxism. The symbol of a reference dentist is bruxism. Being able to stay active in the profession, managing this area without having to operate all day long. Because I'm also an implantologist. Without spending the whole day in surgery, I can now direct my field of work toward this area of bruxism control, which has a vast field to be explored.
Very well. So that's why I want to see you at the Advanced Dentistry Week. As Sergio said, the diagnostic splint is an open door for you to close treatments. The patient connects with you. They connect, they believe in what you're saying, in what they're seeing, and everyone likes to see things to make them tangible. So the diagnostic splint, the examination of the diagnostic splint makes what the patient does at night tangible and convinces them. And we need this certainty, this assertiveness to move forward with our treatments in any area of dentistry. Remember that the Advanced Dentistry Week is an exclusive event for dentists. It's a 100% online free event. And there I will teach you how you can become a reference dentist in your region, increasing your revenue even if you don't currently charge for consultations or work with health insurance plans. Through this, using the methodology of differential diagnosis, treatment, and control of bruxism. The link is here in my Instagram bio or here in the YouTube comments. And it's essential that you provide your best email and your WhatsApp and join the group, because that's where I'll be sending articles. I showed a bunch of articles here in today's class. I'll be sending articles, I'll be sending content, I'll be sending PDFs, I'll be communicating with you. Don't leave the group. My team will be talking to you. In the WhatsApp group, stay tuned to messages from my team who are the group administrators. So kisses. There's a class tomorrow as well, and on Friday.